We want to train our focus on a different issue here in the market, where on Thursday we talk about business issues, but of course also today we train our focus on what is happening in the health sector as far as medically assisted therapy is concerned. And we joined this morning to just drill deeper on this particular matter with a panelist who are already here to tell us more about medically assisted therapy in Kenya, what it really portends. Of course, we have a case study, and we have also a consultant psychiatrist from the Ministry of Health. This is Dr. Karanja, and Felix also, he's here with us this morning to tell us also his side of the story of how he was an drug addict and how he's plucked from that barnacle of drug addiction. Right, so this morning, allow me to introduce to you Dr. Karanja. Good morning, and thank you for joining us on AM Live. And Felix as well, who is MAT champion, which is the medically assisted therapy in Kenya. Right, let's just begin from trying to define for viewers who are waking up this morning and they're wondering what is medically assisted therapy in Kenya and what is essentially medically assisted therapy. Dr. Masi.
Thank you and good morning.
Good morning.
Medically assisted therapy is a treatment that is offered to persons who are dependent on drugs.
Yes.
Specifically opioids. In our case, most of the time, the opioids that is commonly used is heroin. And this is a comprehensive package of interventions that is aimed at reducing the harms that are associated with drug use. Mm-hmm. And this could include HIV transmission, which is quite common and quite high amongst persons who inject drugs, and it offers other services including treatment for and assessment for tuberculosis, sexually transmitted illnesses, prevention of sexually transmitted illnesses, and also provides an opportunity for these persons to be offered counseling for their addiction and services, psychosocial support to be reintegrated back into society. Mm-hmm. Yes.
And of course, this is also part of a campaign. I think also the National AIDS Control Council has been trying to, champion. We had recently also a conference, I think, in connection with Kanko, where we had the harms reduction and what it's really doing in this country. We know that methadone is what has been helping the victims. And of course, also this has been given, or is being given in various hospitals in this country. First of all, we know just the Kenyan government accommodating a methadone was a big deal. Other countries also followed suit because we saw the victories that methadone has done in this country. Tell us what about, just a bit about methadone, because we cannot really uncouple medically assisted therapy without methadone. What is it?
So yes, methadone is a medication that is used for maintenance of these persons who are dependent on opioids to prevent them from going back to using heroin. Mm-hmm. It is a medication that is globally used, yes, and it has been used for many years for treatment of persons with opioid addiction. Mm-hmm. And what it does, it reduces the craving for heroin and other opioids, other mm-hmm. drugs of abuse. Then it also helps, even if somebody takes heroin and they're on methadone, they don't get a high. Mm-hmm. Methadone itself does not cause any high. So it is well documented and well researched and scientifically proven to work in persons who are dependent on opioids. And in Kenya, it's been a long journey in establishment of harm reduction services, not just methadone maintenance therapy, but even also the needle and syringe programs for the same population. And this is in the aim of reducing HIV prevalence and yes, epidemic that we find that most of the current numbers of HIV-related transmissions mm-hmm. are related to injecting drug use. Mm-hmm. We find that the prevalence of HIV amongst males who use who inject drugs is yes, almost 18%, while amongst those, the women who inject drugs mm-hmm. is up to 44%. And any new HIV infections, about 30% can be attributed to injecting drug use. Mm. And therefore, that's why there's need for this program, both the methadone and the other components of the comprehensive package of intervention for this population. All right.
Let's hear from Felix, because yes, you are a beneficiary of this particular program from the Ministry of Health, also the National AIDS Control Council. Just tell us more about your journey, right, to actually being delivered from drug addiction, and are you in the process? And so far, how has the success been? Good morning.
Well, good morning, everyone. My journey started maybe 20-something years ago when I, maybe due to peer pressure, I fell into the drugs problem, and it's been quite a journey because earlier on there was nothing like methadone, and rehabilitations were quite expensive.
Yes.
And I think that kept me going until when methadone came into the picture. And it was different because it's an outpatient thing. You just go in the morning, you have a dose, and it takes care of you the whole day. So it saved so many people who are facing the same predicament I was facing. And I think
That's it.
Yeah.
That's it. So how did it begin? You say peer pressure. Was it in school? Was it,
No,
Dani? Where did it actually?
After school.
After school.
After school, I was trained to be a disc jockey in Mombasa. So that's where I first met people who were using drugs. And I got into that circle. After that, I moved back to Nairobi after working maybe for a year at Mombasa. I came back to Nairobi, and since I didn't come from a very wealthy background, I had ways and means of how to get money. So I could afford the drugs, even if it's so expensive. I could still afford that to get the drugs. And I think because there was no solution, I couldn't find any solution. That's why I kept on going, because until maybe 5 or 7 years ago, I had reached the rock bottom. I had had enough, but there was still no solution. So that's when methadone came into it. I've gone through a lot. I've gone through work. I've gone through so much. You can't balance drugs with work, with normal life. You can't balance it.
You can't balance. But so how did you come to be, aware about MAT and what also the Ministry of Health through NASCOP is doing with methadone?
So there are CSOs which came into the picture. For example, SAPTA, MDM, NOSET. There are quite a few. So nearest to me was SAPTA, and I had friends who had already started working at SAPTA as peer educators and outreach workers. So among those friends was a good friend of mine who introduced me when methadone was just around the corner. People had already gotten wind. People who were in the CSOs, they had already gotten wind that methadone was coming into the picture. So I got a friend who alerted me, and we waited for maybe 2-3 months. Then methadone came into the picture. And it wasn't hard to get into the program, because once, if you're serious, once you go for an interview at the DIC, that's the drop-in center for an organization like SAPTA. They have got their drop-in centers where drug addicts go, maybe have a shower, have a meal, have somewhere you can wash yourself. They have such centers around.
Oh, fantastic.
So yeah, that's how I got the information, that's how I got the interview, and that's how I ended up using methadone. Okay,
so you being a champion as well, it has been exceedingly beneficial for you.
Yeah.
How have you been able also to make sure that the awareness about methadone is created and you're championing that?
Methadone has done so much for me. If I would just mention that methadone has got me back my life. It's got me back with my family. The relationships, were severed before, but now I think I've got a good rapport with my family members. Apart from that, I got a job at SAPTA, which enabled me to be able to sustain my living, like paying rent and having food on the table. And from that, and from what I saw, because I was among the first group which enrolled for methadone. So I got off early, and I got to see my friends how they were suffering, because within the area I live in, there is a big area where there's a big den. The drugs are sold there. So I could, when you're doing the peer education work, you get to the field every day. You get to see the people who you left behind in the drug problem. And so over maybe the last 2 years, I've been trying so much to give back what I've received. So I've been attending conferences, I've been going for last month we were at the Kenya School of Monetary Studies.
Yes.
Yeah, there was the harm reduction, first East African Harm Reduction Conference. We participated. We had our own stall. I formed a group of methadone users, the people who we joined together. We formed a group, it's called Triumph Network for people using drugs.
Triumph Network.
Triumph Network for people using drugs. So in this group, we try and pool resources and help each other, support each other in talks and financially. And recently we've trying to get mandates to be able to help people in the wider Eastlands area. Maybe we'll get a sponsor and start maybe a project that could pull these people, because I think the main problem which is facing most addicts who are in the program is that most of them don't have skills. So if you don't have skills, that means when you start using methadone, you keep on going back to your old friends. You keep on going back to the old circle. And that's where the drugs are, because maybe for the last 5 years you've been staying around that area.
Yes.
So the friends are still the same. You don't have skills.
Yes.
That is a damper, because the good work people like Dr. Karanja are trying to do is being pulled behind, because if we could get people to come into the picture and offer these people in the program skills, it would make them busy. And I think once you're in methadone, you change the whole perception of life. And if you have something to do which will earn you some money to give you an upkeep, I think many people won't be defaulters.
Thank you. All right, let's come to you, because he mentions if he didn't really have access to a center, then that will have been another, we'll be talking on a very different topic right now. But the fact that we have also the Ministry of Health that are established centers, I'm going to understand you have 7 so far in the country, right? Isn't 7 a bit, it's good, it's a good start, but yes, how are you able also to contend? Because I believe it's not just within these particular counties maybe you've picked, there are many areas. Drug addiction is just, a worldwide phenomenon, and in this country, of course, it should be a countrywide phenomenon as well. So what is, first of all, up your collective sleeves in trying to open up other centers, and how successful are these 7 centers that you do have, first of all? Then you can mention for us where these centers are.
Right. Yeah, indeed, the estimated number of people who inject drugs are quite many, almost 24,000 countrywide. We find the majority of them are concentrated in the major cities, especially Nairobi and the coastal towns in Kenya. And the Ministry of Health, through NASCOP, with the support of PEPFAR, has established several centers. The program started in 2014, in December, here in Nairobi, at the Madari Hospital. And so far, we've been able to reach almost 2,500 clients who are now on methadone. And you can see that's just the tip of the iceberg.
Yes.
We still have many more to reach. So over the years, the government has continued to partner with even the civil society organizations that he mentioned in establishing more centers and reaching more population who are affected by drug use. And we have centers here in Nairobi. We have 2 at Madari National Teaching and Referral Hospital, which was the first one to be established. Then we have Ngara Health Center. Then moving on to the coast, we have one in Mombasa County, Kisauni Health Center. There's one in Kilifi at Malindi Sub-County Hospital. And in Kwale, there is a Kombani Mat Clinic. Then we also have one in Kisumu, which is at the Jaramogi Oginga Odinga Teaching and Referral Hospital. And in total, all those clinics have managed to reach almost 2,500. There are still plans to continue expanding these programs, and in the next 5 years, we are hoping to reach almost 5,000 to 10,000 people who inject drugs with these programs. And maybe perhaps there will be more clinics established both within those cities where there is higher concentration of drug users, and other satellite sites where there are smaller numbers of people who use drugs, including establishment of mobile vans that will be used to deliver the methadone to people who perhaps live far. One of the challenges we are facing is the long distance that the clients have to travel to reach the methadone clinics. And therefore, decentralizing these services closer closer to where the populations live is one of the aims of the government.
All right, but the government, so then how are you working also in tandem with the counties? Because I think they can actually, health has been devolved.
Yes.
And I think also that will be the beauty now of actually reaching to the communities via the counties. Are you working in tandem with the counties, with some of the, ministers of health within the various counties that we do have? What is the program?
Definitely. The national government, through NASCOP, is leading the program, but at the county level, there is ownership of all the programs, and there is involvement of the counties in the establishment of the programs, both in even the support, because it's partly supported by national government and county government,
yes,
and then the funding agencies. So you find at the county levels, even the staff is provided by the county. All the MAT clinics are located in health facilities that are under the county, and therefore the management really of these programs at county levels is under the county health management teams.
Okay.
Yes.
Then again, we wanted just to know, Marcy, because when we talk about methadone, we don't know in what form it comes. Is it an injection? Is it a tablet? Is it a syrup? Is it maybe a spray? People wonder what is
Yes,
this methadone, and how do we then, try
Administer.
administer it? You can tell us how is it?
So the methadone comes in many forms.
Okay.
Globally, it can come in powder form, in liquid form, or in tablet form, because methadone is also a painkiller, although most of the times it's used mostly for maintenance therapy of opioid addiction.
Yes.
So the methadone that is in Kenya comes in liquid form. That is the methadone we use in maintenance therapy for persons using drugs. And it is administered orally by mouth, so someone has to swallow it. And it has to be taken every day. It stays in the blood system for almost 24 hours.
24 hours.
36 hours. Unlike heroin, which stays for 4 to 6 hours. And that's why you see people who use heroin are always rushing for another fix every few hours.
Yes.
And it's a habit they have to do every day. So when someone takes methadone every day, once a day, they're able to function the rest of the day without feeling what we call withdrawal, like sick, for lack of opioids in their system. And also it enables them to go about their jobs. And one habit that is associated with heroin is it's a tendency to criminal behavior, to sustain the habit. Because heroin, as you mentioned, is quite expensive. But with methadone, it's provided free of charge in these MAT clinics that I've mentioned in the country. And therefore, it is affordable. And we also have noticed a reduction in the criminal behavior amongst people who use drugs when they are on methadone. So, yes, methadone is a liquid, and it is taken by mouth.
All right.
Yes.
So what happens if I miss my doses?
So,
Maybe, we can go to to Felix to tell us if you've missed your doses. So today, you don't get it. What happens to you? Do you get like those checkups and withdrawals, or what?
For methadone, it's quite potent, and it depends on what you've mixed with, because right now as peer educators, we're having a problem with overdose that is creeping up slowly, and that is because people are going to the clinic, they take the methadone, maybe a high dose of 100, maybe, and 20 milligrams, and when you mix that with alcohol, it's very potent. You're bound to, that's an overdose, I think. And for others, they are mixing that methadone with marijuana. Others are mixing that with amphetamines, which gives a person a very drowsy effect. So we really have a problem with that. We've already started a campaign. I even did illustrations in the clinic talking about that mixing effect. I've done illustrations in the MAT clinic in Madare, which maybe the induction, the new patients can have a look and maybe put it in mind. Yeah, so it's quite potent. You can't mix methadone with anything. And if you're a client and you are really, really keen on recovery, once you're on methadone, you're supposed to cut off everything, even as far as cigarettes go. It still has an effect. So if you can't be able to cut off everything and just be on methadone only, it's very okay with your body.
So how is it if you start taking methadone? Is it just instantaneous, snap of a finger, then you actually get the effect, or it is gradual, you know, incremental?
So just to add on to what you have said,
Yes,
methadone, the way we provide it as a medication for medically assisted therapy, it's not a single dose that fits all, suits all, and it's not dependent on how much heroin you used to use. So the dose depends on an individual, and we give incremental doses over a period of time. We call it, there are stages of getting onto the regular methadone dose for an individual. So we start at induction at a very low dose of methadone and gradually increase it as we assess the client over the days and weeks to see whether they have stopped having this, what we call withdrawal symptoms. Withdrawal symptoms are a cluster of syndrome that you develop when you stop suddenly using heroin or other opioids. Includes what you're saying, shakes. Most of the times they'll have tearing, running nose, a lot of pain in their body, running diarrhea, things like that. So we assess over the time, are the withdrawal symptoms reducing or have they stopped? Once the withdrawal symptoms stop completely, we know that now you have reached your stable maintenance dose of methadone, and we maintain you on that. The nature of most drug users is that they will use more than one drug at any given time of their life. Majority of the drug users, we call them polysubstance users. And therefore, when they come to the clinic, we also assess the other drugs they're using and give them adequate addiction counseling so that they can stop the other drugs, because as is mentioned, if you combine methadone with the other drugs, there's a risk of overdose. There's also a risk of it not being important enough for you with some of the drugs. So we advise people do not combine it with other drugs, and we encourage them to cease use of the other drugs. So we offer other addiction services concurrently as much as we're addressing the heroin use. And methadone,
but to be very clear, other drugs will be, you know, abusive drugs.
Yes, abusive drugs.
It is not medicated, you know, of course, medical drugs, I should say.
Yes.
Yeah?
Yes.
Or prescribed, you know, from the hospital.
Well,
so that cannot really affect, or?
So, you know, all medications are drugs, but not all drugs are medications.
Semantics. Let her finish, then we'll come to you.
Yeah. So some of the prescribed medications may also affect methadone. So, for example, some of the sedatives that may be prescribed by a doctor may have an additive effect on methadone. And there's another level of interaction. Some of the medications that we use, for example, for treating HIV may decrease the level of methadone in your blood system because they cause what we call, they make the methadone be broken down faster, metabolized faster by the liver. And in those circumstances, we then need to adjust the dose of methadone and raise it a little bit so that now the person goes back to the level. So that's why we provide these as a comprehensive package of intervention. And most of the clinics are a one-stop shop. They get all the health services there to avoid the clients going to another center where they're given medication that may interact with the methadone and lead either to inadequate effect of the methadone or lead to an overdose. So there could be interaction with both prescribed medication and abused drugs. But this is in very, very rare cases, and that is why we offer adequate counseling to all the clients even before they are enrolled onto the program.
All right. Rolling into the program, and of course, this program, then will you tell us, sorry, I need to come to Felix before I continue with my train of thought with you. You wanted to actually help Dr. Mercy on that particular
most of the drug users out there normally use illegal substances, that is marijuana, amphetamines, which I think are used in the mental hospitals to maintain mental disorder patients, if I'm not wrong. And I think there's only, one incident where we know there is a medication which is in the chemists for a problem maybe in a human being. And people use that to get high once they overuse it.
Yes.
Because maybe for the patient, you'll just be advised to use maybe a small dose. But for you, the abuser, you will take a large amount, which will give you that high effect. So I think Rohypnol was in the market. I don't see it these days. And codeine also has been used. So if, in any case, if you want to recover using methadone, you have to kick off the other habits. You have to maintain methadone for maybe 3 or 4 years until when psychologically you are able to be weaned off, because because if you're mixing, even if it's marijuana or cigarettes, you will have a problem when you're weaning off, because then the dose starts going down. And when the dose starts going down, there'll be a gap left, because you've conditioned your mind to use two highs. So that makes a double effect. So when they take down the dose, that effect goes away.
Okay.
So you start having problems, the withdrawal effects start coming back. And when you go to the clinic, they'll definitely notice. And I think every 3 months you have to go through toxicology. It's a must. So it's just randomly done. If you've been taking heroin in between, marijuana, anything, it will show up. And then the doctor can't really prescribe you with more methadone until you've undergone some counseling.
Okay.
And that's when you can get more methadone.
All right. Yeah. Felix mentions codeine, and maybe you can try, because there's been an abusive use of codeine as well, and many people know they're hiding under codeine. This is just becoming another, first of all, for the benefit of our viewers who really don't know, or they've never really taken codeine, what is codeine? And how even high school students actually, under the name of, medication, I have a cough syrup here, we allow them to schools, but actually in there, it is really laced with so many drugs that people are not really aware about this. Very briefly.
Yes, codeine is a medication that is used for pain, and it's also added sometimes in cough syrup because it helps with suppression of coughs.
Yes.
It falls under the categories of drugs we call opioids. Like I mentioned earlier, opioid is a class of drugs that originally they come from opium. And there are those that are naturally occurring, and there are those that are synthetically manufactured. So codeine actually comes from the natural opium together with morphine, all right? And they're usually very potent painkillers, and they're used in persons who have severe pain. So codeine, morphine, they have the potential to give a high, to cause, so people abuse them to get a high. Most of the times you find people will start using them from as a prescription medication, then they realize later that either they were prescribed for too long and they can no longer get off it, or some just learn of the high they get when they take the codeine and now they start abusing it. Yes, so that's why you see people will abuse codeine as a tablet or the cough syrup, because codeine is contained in some cough syrup, not all cough syrup.
Not all cough syrup.
Yeah. Yes.
Okay. Maybe as we're winding up, and of course also Felix will give us your parting shots as well. Tell us the role of, because of course you bankrolling this particular program is expensive. And also people like Felix, as we are aware right now, at least he has a source of living. Before, drug addiction can really waste you completely, where you just become a basket, and any money that you actually get goes into, accessing the drugs as well. So in terms of accessing the medical care, is it free, and how are you able as a ministry also to continue with this particular program sustainably? Because people, if we lack these drugs, then it means also people like Felix also relapse, and then we go back to square A.
Okay, so the medically assisted therapy program has actually been a partnership, but spearheaded by the government.
Yes.
The government has invested heavily in the medically assisted therapy program and other harm reduction programs for people who use drugs. And it's also funded by PEPFAR through various organizations. PEPFAR funds CDC and USAID, and you find that we'll get implementing partners funded. At the coast, we have the UNODC supporting the coastal programs. In Nairobi, you have University of Maryland. In the Kisumu, we have ICAP supporting the program under funding from the PEPFAR. Then we have the government funding. Then we have the civil society organizations who have also funding, also some from CDC, Global Fund, and so we have civil society organizations such as SAPTA that he mentioned, NOSET, MDM. We have others at the coast like MEWA, Reach Out, Teens Watch. We have several civil society organizations. The services offered at the civil society organization level in the drop-in center are free of charge, and they concentrate mostly on the package without methadone, but the rest of the comprehensive package. They'll offer needle and syringe programs, they'll offer HIV services, STI, TB treatment, all that. And then in the medically assisted therapy program, services are also free. and the government has guaranteed that there is investment to ensuring that even when the donor funding is cut off, there will be continuity and sustainability of these programs. So we shouldn't be worried about people being on methadone and then it's cut off, because even currently the government is hoping to introduce other medication for maintenance, because methadone is one of them, but there's another medication called buprenorphine that the government is planning to introduce to be used alongside the methadone.
Thank you. All right, Felix, maybe your parting shots also as you taking this medication and you being the MAT champion. So how would you, for the benefit of a person who's watching this morning and want to access this medical facilities, the nearest place that will be Mathari in Nairobi, but as a champion then, how do you also create this awareness? What is your strategy? Very briefly.
The strategy that I have in mind right now, it's just that I've not gotten enough sponsorship to be able to launch what I'm thinking. But I was thinking about a drop-in center that would be solely run by people who have gotten off the methadone program. Because these are seasoned addicts. They know what it entails. And if I would use such a team to go out and outreach, it would be very much effective. And also I was thinking about, at the same time, if that drop-in center would probably have a section to house the people coming into methadone, because it's common knowledge that every addict doesn't have a place of abode. So they live off the streets, maybe with friends and such things. So if we had a place to house them and then have a place we can cater for them and teach them skills while they're still in the methadone program, and so that we have people who will help building the nation in the future.
Thank you. Thank you. All right, Dr. Mercy Karanja, I know we can actually talk hours on end on this, and I promise, I think we need to also have a very comprehensive discussion on this.